objective is to stage the tumor. So you want not only want to confirm the diagnosis, but want to see the extent, whether it is only supraglottic, whether the vocal cord are involved, or whether the subglottic is involved. The important part of clinical examination in your clinic and outpatient with the mirror of the pyroptic laryngoscopy, if you are seeing a tumor, is to assess the mobility of the vocal cord, whether the vocal cord are mobile or not. If the vocal cord is fixed, that means the tumor has invaded the cricoarytenoid joint, or if the vocal cord is paralyzed, that means the tumor has involved the recurrent laryngeal nerve. So under anesthesia, often you cannot see the mobility of the vocal cord. So in the clinic, it is when you are seeing the tumor and you are seeing want to see where the tumor is coming from, right side or left side, supraglottic or glottic, you must try to see the mobility of the vocal cord. If the vocal cord is fixed, then it straight away becomes T3 or stage 3. If the vocal cord is fixed, it is T3. Remember that. Okay. So you stage the tumor. So you want to see the site of the tumor under the anesthesia as well. You always try to see the site with the fiber optic mirror, laryngoscopy, or with the mirror, but sometimes if it is large tumor, you cannot see the extent. So under anesthesia, you have got more time. So before you take the biopsy, you see the extent of the tumor, because the moment you take the biopsy, there will be a little bit of bleeding and you may not see well. So once you see the tumor, instead of rushing to the biopsy, you first see where the tumor is. Is it involved the false cord, ariepiglottic fold, epiglottic, vocal cord, and is it going to the hypopharynx, that is piriform fossa or post-cricoid region? Okay, so you want to see the other part of the larynx. Okay, that is hypopharynx. Anterior commissure is important. Now, anterior commissure, if you remember your anatomy, there may be small tumor involving the vocal cord and anterior commissure, and there is a very thin anterior commissure is attached to the thyroid cartilage with a thin tendon. It's a very few millimeter area. So in some cases, tumor may be very small, but it may have invaded the thyroid cartilage. And if it has invaded the thyroid cartilage, it is T3. And if it has gone through and through, it becomes T4. So that is why on the CT scan, you would like to see very clearly whether the anterior commissure is involved, and also in the when you are examining under anesthesia, whether the anterior commissure is involved or not. All right. So you not only see the site of the tumor, but extent of the tumor. Other part of the larynx means that whether it is gone to this glottic, subglottic, transglottic, involved the hypopharynx, or sometimes it may involve the base of the chest. Okay. Mobility of the vocal cord, as I have already emphasized. If it is fixed, it becomes T3. So this is the picture where anterior commissure is. This is a thyroid cartilage. This is the anterior area, and vocal cords are at the upper, somewhere between the midway between the thyroid cartilage, or at the junction of upper 2/3 and lower 1/3. And it is very close to the anterior commissure. So it is in very early stage, it may be involved. This is a tumor right side, and it is going to the anterior commissure. So here is the thyroid cartilage. Although it is very small tumor, but when you are looking at the CT scan, look specifically for the erosion of the thyroid cartilage, because it affects your staging. It becomes T3, or if it is through and through, it becomes T4. And ask also, when you're making a request for the CT scan, ask the radiologist, please comment on the anterior commissure. Not a radiologist, do not comment on this. So you have to be very specific. Whenever you are asking for CT scan of any part of the body, you should have some objective, and you please ask the radiologist to comment on those things, on those areas. So in the larynx, you ask for whether please tell us whether the anterior commissure is involved, whether the thyroid cartilage is eroded, whether the cricoarytenoid joint is involved or not. These are the things which a good radiologist center and good radiologist can tell you. So always just writing the CT scan of the larynx and neck and chest is not enough. Ask a specific question from the radiologist. This is another picture of the tumor on the. This is right side. This is left, and this is from getting removed. Okay, direct laryngoscopy when you are doing under anesthesia. So the right become left, left become right, because the patient is lying flat and you are on the head end of the patient. The patient left is this. So whatever is the patient left, it becomes the left Okay, so do not get confused between direct laryngoscopy and indirect laryngoscopy. In indirect laryngoscopy, this is the right, this is the left, because patient is sitting in front of you. I'm repeating myself because even the senior resident gets confused. So if the patient, always look at where the patient right or left is, and then accordingly you can say this is the right and this is the left. This is left, this is right, and this polypoidal mass involving the left vocal cord and anterior commissure. It may be benign, it may be malignant. This is thickening and white plaque, that is leukoplakia. It could be leukoplakia, there could be early stage carcinoma in situ or carcinoma. So always, whenever you see this picture on the indirect laryngoscopy or fibroscopic laryngoscopy, always ask for biopsy. Okay, this is another picture of larynx, and this is if we are looking with the direct laryngoscopy. So this is left, this is right, and this is arytenoid left side and epiglottic fold. This is normal, and you can see this is fallen on the right side of the patient. Okay. These are another picture showing the tumor. Another picture of the piriform fossa. Okay. This is anterior commissure. This is posterior commissure. So this is fibroscopic examination. So this is patient right. This is patient's left. So on the right piriform fossa. Okay. And I mean, you cannot tell whether it is piriform fossa or whether it is epiglottic fold, because it may be arising from the epiglottic fold, and there is the piriform fossa. Like here, this is normal side epiglottic fold and piriform fossa. Okay. So then, if this is so, you write down there's a mass in the region of the supraglottic region, and it may be involving the piriform fossa, which you will determine with the CT scan and also under anesthesia with direct laryngoscopy. Okay, TNM staging, we did it with oral cavity carcinoma. Here it is different. In oral cavity and oropharynx, you classify T stages with the size 2 centimeter, 2 to 4, or greater than 4. In the larynx, it is different. So whenever you are examining the larynx, you want to see which side is involved. Is it one side that is supraglottic only, or is it going to the subglottic or glottic? And vocal cord mobility. So these are the two things which you want to see, and then stage the tumor accordingly. Vocal cord mobility and number of subsites, which are supraglottic, glottic, and subglottic. And presence of nodes. So these are the three areas whenever you are going to stage it. So staging can be done clinically with clinical examination, and can be confirmed with the radiological examination. Okay, this is American classification TNM staging. Okay, so T is where the tumor is arising from, which part of the tumor. So TX is primary tumor cannot be assessed for some reason. T0, no evidence of tumor. T1 is carcinoma and C2. So on examination, in these cases, there may be leukoplakia, or vocal cord may look red and thickened. So anybody who has got hosts for more than 4 weeks and vocal cord is red and thickened and it's not settling down, so do not think that it is a laryngitis. It could be a malignancy. So any patient who has got hosts with a suspected lesion in the vocal cord or the larynx, you must biopsy. So coming to TNM classification, T1, T3, and T4. So T1 is tumors just affecting one subside, okay, and with the mobile vocal cord. T2 is it could be involved in the supra. Okay, the tumor could be involving only more than one side. In this, tumor may be involving the epiglottic only, or epiglottic fold only, or false cord only. But in this case, tumor may be involving from more than one subside of the supraglottic. That is, it could be involving to the epiglottis and epiglottic fold. Okay, or it can be involving the vocal cord. Okay, so T1 is just one subside. T2 is more than one subside of the supraglottic region. That is, it is not only involving the epiglottic, it may be involving the epiglottic fold. Or if the tumor is involving only the one side of the supraglottic and has also involving the vocal cord. So any tumor which is involving the supraglottic and glottic becomes T2. Okay, and T3, regardless of which site is involved. If the vocal cord is fixed, then it is straight away T3, simple. And T4 you can only diagnose radiologically if it has gone outside the larynx. Okay. So T3 and T4 limit vocal cord fixed is T3, T4 it has gone beyond the larynx. T1 is very early stage tumor. T2 is involving more than one side subsite or is all extending from supraglottic to glottic region. Glottic again tumor limited to one vocal cord. Vocal cord or mobile tumor extend to supraglottic or subglottic. All vocal cord mobility is impaired. It is not completely fixed. With slight movement, it becomes T2. T3 is again vocal cord is fixed. T4 again same. The subglottic again same is limited to one subsite, that is subglottic, or the extent to the vocal cords with normal mobility or with vocal cord fixed. So in summary, T1 is limited to one site, T2 is involving more than one site, T3 vocal cord fixed, and T4 is involving beyond the larynx. Hypopharynx again is the same, a little bit different. We measure it in centimeters, like oral cavity. So if it is involving one subsite, that is hypopharynx has got three subsites: piriform fossa, postcricoid, and posterior. Okay. And if it is only involving one area, it is T1. If it is involving more than one area, T2, T3. If it is vocal cord is fixed or greater than 4 centimeters, like oral cavity, and T4 is erosion of the laryngeal cartilage through and through, complete erosion and external outside the larynx. It's like larynx. T3 and T4 is the same. T2 more than one subsite. T1 is one subsite. Okay. Do not get confused with the staging. I don't think that we will be asking at your level about the staging, but that does not mean that you should not know. You should know about it. Just try to make it simple. If you forget and somebody asks early stage and advanced stage, you say advanced stage is T3 and T4, early stage is T1 and T2. Simple. Okay, at your level. And but if you want to take a distinction, you should tell us like then all these staging in detail, then you will get the distinction. Okay, regional lymph node is the same as we did in the oral cavity. One node and more than one node, or 3 to 6 centimeter, and 2 and 3 is greater than 6 centimeters. All right. Okay, metastasis, no metastasis, distant metastasis. Most commonly metastasize to lungs. Okay. Then we stage a PNM staging of any time whenever there is one node, and even if it is T1 and node is pebble, it will straight away become stage 3. Involvement of the only one node becomes stage 3, regardless of the how small the tumor is. Okay, and stage 4, as I said, stage 4, if it has T4 or more than one node are involved, all right, that becomes stage 4. So stage 4 is again, if more than one nodes are involved, regardless of the primary site, primary staging of T staging, it straight away becomes stage 4. Okay, so remember, stage 3 is T3 or single node. Stage 4, T4, that is beyond the larynx, or even if the tumor is within the larynx, but there are more than one node, it becomes stage 4. Stage 4 again subdivided into A and B. B is inoperable. That is involving, it is encircling the lymph node, the carotid. Okay. I won't go into detail in of courses. 4B becomes inoperable because tumors of the larynx may be involving the posterior pharyngeal wall and prevertebral fascia. That is, it is adherent to the posterior pharyngeal wall. Then it becomes inoperability 4B, or if it is surrounding the carotid 360 degree, you can the lymph node is surrounding the carotid 360 degree, and you cannot separate it from the carotid, so it becomes 4B. Okay, so obviously planning the treatment as like in oral cavity, you consult the family about the diagnosis, and the patient is also important, whether you want to tell them about curable or not, and if it is curable, then you want to share, give them a management plan. Sometimes it could be curable, but it may not be resectable. That means you cannot operate because of the poor condition of the patient. Patient may have got a severe cardiac history, or patient is, I'm a 90-year-old patient. I don't want to go and do a major surgery. So general assessment of the health is important. So counseling the family about the diagnosis, staging of the tumor, whether you can operate, cure the patient or not, and what are the treatment modalities which will be involved. So we talked about this in oral cavity tumor. So in the larynx, again, you talk about the diagnosis, the treatment plan, prognosis care, treatment options care, complications, rehabilitation. In this case, about their concern about their voice and following. Okay. And once, if you have done the total laryngectomy, we remove the larynx completely in advanced stages. Then we make a permanent tracheostomy. So it is for care of this tumor. How do you look after this tumor? Time khatam ho raha hai. Okay, so we have got these three options of treatment in carcinoma of the larynx and hypopharynx. So in order to make it simple, in early stage, you want to treat them with laser or chemotherapy or radiation. So stage 1 or 2, or T1 and T2, or small T3. Sometimes tumor may be very small involving the vocal cord, but vocal cord is fixed. So there is 50-50 chance of treating, getting the patient cured with chemo radiation. Okay. Surgery you do in advanced stages. So remember this first. Early stages, laser or chemotherapy and / radiation. If you do not have the facility for laser, then chemotherapy or radiation. And in advanced cases, surgery. Now, patients are concerned about their voice. So, which treatment will get the better? The quality of voice will be better with laser or with radiation. A lot of people think that with the laser, the quality of voice with them would be better. But if the patient asks you and you give the option that we can, it is a very early stage tumor, stage 1, T1, we can treat you with laser radiation only. And the patient will be asked which treatment will be better for me and my voice will be better with which treatment. With radiation, the voice will be relatively better than with laser. Remember that. Laser is a fancy word. Everybody thinks laser is magic, but the quality of voice is better with radiation than laser. Okay. So these are the options in advanced stage. Obviously, you do a surgery and post-operative radiation plus minus chemotherapy. So every tumor is discussed in the MDT or tumor board meeting where there are surgeons, oncologists, radiologists, and plastic surgeons. We discuss these cases. We have got weekly, fortnightly tumor board, ENT tumor board meeting on Monday at 8:30. If you are interested, you can attend it. So this is the summary. Laser in very early stage, T1, T2. Small T3 may, instead of laser, you give chemo radiation, but in these cases, chemo radiation, and surgery in advanced stage. Sometimes, if you do not have the facility of laser chemo radiation and patient has got a very small tumor, so you can do a surgery, limited surgery, like just remove the vocal cord or do the partial laryngectomy. I will not go into detail of partial laryngectomy, but if patient does not want chemo radiation or you do not have laser, and patient obviously in early stage, so you can offer them partial laryngectomy in which you will remove the part of the larynx which is involved, and the patient will not lose the voice box and patient will not lose the voice. Okay. The surgery in large T3 tumor or whenever there are nodes are involved, you offer them surgery rather than the above the treatment. So stage 1, stage 2, stage 3. So this slide says it all. In early stages, these two options, in advanced stage surgery. Okay, partial laryngectomy I talked about. We very rarely do it because of we often send the patient for chemo radiation or if, with the laser. So these are various types of partial laryngectomy. I do not want to go into details with you. And in advanced stage, you do a near total or total laryngectomy. Again, I don't want to go into details, but this is the procedure in which you can remove, leave a part of the iricoarytenoid joint and part of the vocal cord and patient will have some sort of voice. All right. Okay, inoperable कब हो गया? T4B invades the prevertebral space, or in case of carotid artery, I have already spoken about it, or obviously invades the mediastinal restriction. So the rehabilitation of voice obviously is very important in laryngeal carcinoma. So if you have removed the larynx in advanced stage, that is, you have done the total laryngectomy. That means you have removed the tumor was very advanced. And it was involving the going outside the larynx, or there were multiple lymph nodes involved. So obviously this patient would not have got cured from chemo radiation, and you would have to do a total laryngectomy. When you remove the larynx completely, there will be permanent stoma like tracheostomy, and also patient will not be able to speak. So there are various ways of voice rehabilitation, and one is non-surgical. This is very important because some of my patients have gone to speech therapist with the esophageal speech, and then they can speak. I've got a video. I do not know whether this video will run on this or not. I will see if it can. I'll show you. So these are the non-surgical ways. The esophageal speech is the best. It does not involve any surgery, or if the patient is not very compliant, then laryngeal vibrator is a small box, a small rounded box which they attach to the neck, and then it is called laryngeal vibrator. It vibrates the neck muscles, and it produces a voice like a robot. Surgical, you make an opening between the trachea and esophagus. You make a one-way fistula, put a single valve. So the air goes from trachea and esophagus. Remember, how do we speak? Whenever we speak, the air is going there, and it causes the vibration of the vocal cord. Air is coming from the trachea, and it is causing the vibration of the vocal cord. When we do not have vocal cord after total laryngectomy, the air must go from esophagus to trachea, or in this case, is vibration of the esophagus. So, because there is no larynx, patient is not breathing through the nose, patient stoma is in the neck, in the trachea, so the air will go from the trachea to the esophagus, and it will cause the vibration of the esophageal muscle. The vibration of the esophageal muscle after total laryngectomy produces a speech, whether by the esophageal speech or by the surgical method. I will show you one picture. Okay, this is the stoma after total laryngectomy. This is how it looks like. This is a permanent stoma. It will be remain there. The patient is breathing through this. Okay. Now, in esophageal speech, air is going through this, and patient esophageal speech is taught by speech therapist to swallow the air and regurgitate. Swallow and regurgitate is the principle, and this causes the vibration of the pharyngeal muscle and produce a voice. This is the principle of esophageal speech, vibration of the pharyngeal muscle. Okay. पता नहीं वीडियो चलेगी इसमें? ये मेरा पेशेंट है कि हमने he has got laryngectomy done. इसने अपना स्टोमा छुपाया हुआ है, एंड इसको मेरे लैपटॉप पे तो प्ले हो जाती है, पता नहीं यहाँ प्ले होगी या नहीं, मैं देखता हूँ। नहीं होगी या मैंने लेक्चर हॉल पे लास्ट जब फिजिकल लेक्चर में तो प्ले की थी हैं, वीडियो पहले से सिस्टम में होगी तो प्ले हो जाती है। अच्छा, ये अभी प्ले नहीं हो सकती, बट इफ यू वांट टू सी दिस हिस्ट्री यू कैन कम टू मी, आई विल शो यू इन माय लैपटॉप। ये अगर फिजिकल वो होती है तो ऑलरेडी आप लोग सिस्टम इनके सिस्टम में होती है तो दे कैन प्ले, हियर दे कैन नॉट प्ले। So this is the laryngeal vibrator I was talking about. Okay, so if the patient is not, because esophageal speech involves a lot of commitment from the patient. If patient is not committed, then this you give them this device. Patient can speak, but the quality of voice is not as good as with the esophageal speech. It is not natural, and it is like remote. So they attach this vibrator to the submental region where it causes the vibration of the pharyngeal muscle, and a voice is produced. Okay, so tracheoesophageal valve. I talked about surgical restoration. So there is a tracheostoma. We make a small opening just at the posterior end of the trachea to the esophagus and put in this valve. This is a one-way valve. We close it, patient close it, and the air goes from trachea into the esophagus and the pharynx, and then the patient speaks. This is a one-way valve. So when patient is swallowing, the food does not go into the trachea. Okay. This is the closer picture. Okay, so this is the trachea, this is the esophagus, this is the valve. Air is going from trachea. Patient has blocked it so that air does not go out, and it goes from trachea to the esophagus. It goes vibration, it produces the voice. Another picture. Okay, like this. Okay, this is the closer picture of this valve. Various kind of valve can be put between trachea and esophagus. Okay, so in summary, this is how you manage like any other patient. And particularly you want to see stage the tumor and then the various part of the larynx and hypopharynx and the neck, do the CT scan. MRI is not done in laryngeal carcinoma because you would like to see the cartilage involvement, which is better visible in CT scan rather than in MRI. Okay, counseling is an important part, and treatment plan and rehabilitation is one of the most important part of laryngeal and hypophyseal carcinoma. And regular follow-up. All the patients who have a treatment for the carcinoma, they should come on a very regular follow-up to make sure that there is no recurrence. Okay, so this is the conclusion. Symptoms, proper staging, counseling, tumor board meeting, regular follow-up. Thank you very much. Any questions from anybody? Any confusion? No. Okay, I will conclude this lecture. I think hopefully, inshallah, next Friday I will talk about hoarseness of, and the second lecture will be on foreign body. If you come prepared with the hoarseness, what are the various causes of hoarseness, and we will discuss it. Every patient who comes with hoarseness does not have malignancy. Remember that. ऐसा ना हो घर में जाके जिसको hoarseness हो रही है उसको डरा दें आप लोग. So most of them have got benign causes like non-specific laryngitis or vocal cord disease. Anyway, please come prepared, and I would prefer you to ask as many questions, especially if you want to criticize at my lecture, please feel free to do so. You can give it feedback about my lectures, whether should I change the my lecture template. Unfortunately, because of these Zoom lectures, we cannot have a interactive lecture. Normally, I try to ask one of the students to come to the stage and present a part of the lecture, and we try to involve everybody in the lecture and have a discussion, because these are all the things which you can see in the books. But anyway, because of the COVID, there are a lot of limitations in our life, so we have to get the best out of it. Thank you very much. Good luck. Bye.